the slideshow, please. I would request to please start the slideshow.
Yes, sir.
Yes. Next, please. So the idea that true addictions can exist even in the absence of psychotropic drugs, that is behavioral addiction, was popularized by Peel way back in 1979. And according to Peel, addicted individuals are dependent on a particular set of experiences of which the reactions to a specific chemical substance is only one example. Building on Peel's notion, Griffiths and Young, they developed the idea that addiction does not necessarily have to involve the abuse of a chemical intoxicant or substance. Next, please. So several behaviors besides psychoactive substance ingestion, they do produce short-term rewards that may engender persistent behavior despite the knowledge of adverse consequences. That is why they are addiction. Diminished control is a core defining concept of psychoactive substance dependence or addiction. And this similarity has given rise to the concept of non-substance or behavioral addictions, that is, syndromes analogous to substance addiction, but with a behavioral focus, other than ingestion of a psychoactive substance. Next, please. Next, please. Can I have the, yes. So Goodwin, in 1990, he gave a lot of A, B, C, D, E, and F. And in A, he said, recurrent failure to resist impulses, to engage in a specified behavior. Recurrent failure to resist impulses, to engage in a specified behavior. B, he said, increasing sense of tension immediately prior to initiating the behavior. C was pleasure or relief at the time of engaging in the behavior. A feeling of lack of control while engaging in the behavior. So that is why, it's wrong. And out of 9 criteria, I said 5 should be present. One is frequent preoccupation with the behavior. Number 2, frequent engaging in the behavior to a greater extent or over a longer period. Third, repeated efforts to reduce, control, or stop the behavior. Repeated efforts. Fourth, a great deal of time spent in the activities necessary for the behavior, engaging in the behavior, or recovering from its effects. The fifth, he said, frequent engaging in the behavior when expected to fulfill occupational, academic, domestic, or other social obligations. 6, important social, occupational, or recreational activities given up or reduced because of the behavior. 7th, continuation of the behavior despite the knowledge of having a persistent or recurrent social, financial, psychological, or physical problem that is caused by the behavior. 8 is tolerance, that is the need to increase the intensity or the frequency of the behavior to achieve the same result. And 9, restlessness or irritability if unable to engage in the behavior. So out of these 9, any 5, and that's it. And he gave a time period of 1 month. Some symptoms of the disturbance have persisted for at least 1 month or have occurred repeatedly over a longer period of time. Next, please. Griffiths. Back, please. I'm on slide. Am I on? Back, please. Back. One back. That's Griffiths. So Griffiths gave a very, very important concept. He gave the concept of salience, mood modification, tolerance, conflict, and relapse. Salience is when the particular activity becomes the most important activity in the people's life and dominates their thinking. That is preoccupations and the cognitive distortions, the feelings, that is the cravings, and the behavior, that is deterioration of the socialized behavior. The second concept he gave was mood modification. That is a consequence such as a arousing, buzz, or a high, or a feeling of escape, of engaging in a particular activity can be seen as a coping strategy. Of course, he gave the concept of tolerance. Then he gave the concept of conflict, interpersonal conflicts between addicts and those around them, or intra-psychic conflict within the addicted individual, that is between the psychological need to engage in the activity and the desire not to give in to the tensions caused by addiction to the activity, and of course, relapse. Next, please. The characteristics of addictive disorder coming to recurrent failure to resist the behavior, an increased sense of tension or arousal prior to the involvement, as we have just now seen in both of these criteria, pleasure while experiencing the behavior, and feelings of remorse and guilt over doing the behavior. Next, please. How have they been defined? The essential feature of behavioral addictions is the failure to resist an impulse, drive, or temptation to perform an act that is harmful to the person or to others. Each behavioral addiction is characterized by a recurrent pattern of behavior that has this essential feature within a specific domain. Next, please. Craving ecstasy. Well, there are three types of highs. One is arousal, one is satiation, and one is fantasy. Now, arousal, sensation of intense, raw, unchecked power, feelings of being invulnerable, all powerful, like gambling, sex, spending, stealing, satiation, full, complete, numb, beyond pain or distress. That is the food addiction, the TV addiction, the video poker, fantasy, the imaginings about the addictive experiences and the euphoric recall. Next, please. From a neurological point of view, behavioral addictions that only indirectly affect the neurotransmitter systems of the brain can serve as reinforcers comparable to pharmacological substances that directly affect these symptoms, like the dopaminergic system. Now, indeed, recent findings support the assumption of a common mechanism that underlies the development and maintenance of both behavioral and substance-related addiction. Next, please. What are behavioral addictions now? Gambling disorder, internet addiction or gaming disorder, sex addiction, exercise addiction, shopping addiction, compulsive buying, shopping addiction, excessive eating. All of these are behavioral addictions. Next, yes. So the current diagnostic status, DSM-5 has gambling disorder and the substance-related and addictive disorders, and internet gaming disorder has been kept in the section 3 of condition for further study, so likely to be included later on. And in ICD-11 again, gambling disorders still remain in the impulse control disorders, but problematic internet use is not included because of the lack of the scientific evidence till now. So we need much more research. Next, please. When you look at DSM-5 gambling disorder, what does it say? Persistent and recurrent problematic gambling behavior with more than 4 criteria within 1 year. That is, one needs to gamble with increasing amounts of money in order to achieve the desired excitement. That is the tolerance concept. Number 2 is restless or irritable when attempting to cut down or stop the gambling, that is withdrawal. Third, has made repeated unsuccessful efforts to control, cut back, or to stop the gambling. Fourth, is often preoccupied with gambling. Fifth, often gambles when feeling distress, like a coping mechanism. Number six, after losing money gambling, often returns another day, I get even. Then, seventh, lies to conceal the extent of the involvement. No, I'm not involved at all. No, 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 it's not. He realizes the thing, but it's not beyond. It's not. It's beyond his control. Has jeopardized or lost a significant relationship, job, education, career opportunity because of this faulty behavior of gambling. Relies on others to provide money to relieve the desperate financial situations caused by this behavior. That is next, please. Then let's look at internet gaming disorder. Again, repetitive use of internet-based games, 5 out of 9 criteria must be met within 1 year. Preoccupation or obsession with the internet games. This is exceedingly coming in all to our OPDs, and we really need to focus on this. Number two, withdrawal symptoms when not playing the internet games. The parents come with these problems that my child is having this problem. Third is a buildup of tolerance. More time needs to be spent. Number four, tried to stop or curb playing. Has tried but has failed to do so. Number five, had a loss of interest in other life activities. The other hobbies take secondary. This becomes primary. Number six, continued overuse, even with the knowledge of the hazardous impact. Number seven, lied to others about his or her internet game usage. And number eight, uses internet games to relieve anxiety like a coping strategy and lost or put at risk opportunities or relationships. That is internet gaming disorder. When you look for this in the OPD, you will exceedingly find it. Next, please. Net has increased and compulsive shopping has increased. Similar to gambling, come to feel worth and self-esteem from the shopping experience. Yes, the self-esteem increases. There is a fantasy of specialness and respect from the salespeople. There is a belief that buying will bring one closer to the ideal self. Becomes impulse control issue also. What are the warning signs that you have to tell the parents? Arguments with others about spending habits, feeling lost without your debit cards, many purchases, though they are purchased, they're never used. Lying to others about what was bought or how much money was spent. No, I spent only 4,000. No, you spent 40,000. No, just 4,000. Spending a lot of time juggling the accounts and the bills. Next, please. Exercise addiction. Oh, this is special, very, very relevant to today's society. Look for it. Feel depressed, guilty, or tense if you don't get to exercise every day. You work out, even if you're ill, you're injured, or you're having a dangerous condition, you still have to work out. You push everything else in the life aside. This becomes primary, everything else secondary. And also, there's a lack of satisfaction after exercising. That is exercise addiction. Next, please. Next, please. Cybersex. Cybersex, it triggers the reward pathway. There is dopamine flooding. It recircuits the pathways. We are talking about pathways. It takes away receptors, leads to tolerance, and this is increasingly common. Next, please. What are the consequences? Addiction, if it's behavioral addiction, has to have consequences. There are social consequences. There are serious relationship problems, whether you are married or you're single. There are financial losses or theft. There's impaired functioning at work, poor academic performance, your sleep is deprived, lack of the proper exercise is there, and so many other conditions. Next, please. Next, please. The psychological, it has high comorbidity. That is a big problem. Gambling disorders, in mood disorders, the comorbidity is from about 15% to 77%. Any anxiety disorder from 7% to 40%, and SUDs 31 to 60%, alcohol use 26 to 73%. That is the level of comorbidity. Major depression 33%, one third to three fourths. Internet addiction, 8 studies have been done, and they've been found a significant positive association between internet addiction and alcohol abuse, ADHD, depression, anxiety. We'll talk about internet addiction shortly. Now I'm going to share, next please. Now I'm going to share with you something new about the management because all of these things are very new. And what we are doing, the model of management that we are doing, I'm going to just share with you. Management depends on a thorough clinical history, collaborations from significant members, the demographics, the behavior, you all know that, the consequences, the contributing factor. But how will you manage? You need the screening instruments and you need the diagnostic instruments. Now, in these screening instruments, because stress is a major entity, the Student Stress Dimension Questionnaire, developed in 2016 and validated, becomes exceedingly relevant and very important. Next, please. Yes, thank you. The treatment goal in gambling disorder is complete abstinence. In problematic internet use is abstinence from the problematic applications and a controlled and balanced internet usage. That is what we want to achieve. And for the management, we have non-pharmacological basically, and some sort of pharmacological is also there. Next, please. We look at online addiction now. How will you manage that? Well, it's similar to substance abuse prevention programs aimed at addicted persons. Specialized training can educate adolescents about the warning signs of online addiction in order to assist early detection of the problem. Parents should inform their children about the negative consequences of overuse of the internet and its moral deviations in order to prevent the addiction. Once the child is loaded with the knowledge, the person knows that I have to take this, I have to tread with caution. Parents should also monitor their children while using the internet and teach them the useful and appropriate methods of internet use. This most of the people do not know because many other times the family members, they are sort of ignorant about the internet use and the children are more into it. Behavioral science professionals might help adolescents understand the factors underlying their online habits and reintegrate the former activities into their lifestyles to prevent suspected cases of online abuse. And it's important to know that prevention programs for online abuse can reduce the occurrence of future incidents. So prevention programs are very important. Next, please. One of the important ways to prevent internet addiction is to treat the risk factors like loneliness, stress, depression, and anxiety. These may trigger the addiction to the internet and they should be treated. Now, mental health professionals should encourage individuals who overuse the internet to seek treatment when problems emerge and help them identify ways to reduce cumulative stress load. Now, this is a new term that we have coined, that is cumulative stress load. And we will, lastly, we should realize that filtering is necessary and can limit the abuse of internet that is like the pornographic sites, but can only be temporary. In the current situation, the government, we urge, should invest in promoting constructive use and positive ideation, strengthening of religious beliefs, and improving the spirit through positive psychiatry campaigns aimed towards this. Next, please. Now let's look at the non-pharmacological, though motivational enhancement therapies, CBT, commonly used to treat substance use disorders, have been successfully used to treat pathological gambling, compulsive sexual behavior, kleptomania, pathological skin pricking, compulsive buying, and all of these things. So, along with this, one very important thing about starting non-pharmacological is to identify the daily life stressors and the triggers. And you can do this excellently with the use of the student stress dimension questionnaire, which I'll be just sharing with you in some. Now, we know that stress and behavioral addiction is very, very relevant and they are interrelated. Stress is there. Next, please. Next, please. Now, we know that stress is there in various life domains. Now, the common daily stressors, they are very, very important. People ask why this is happening now, why this was not happening earlier. Now, this is the concept of the common daily stressors. There are so many daily stressors which are stressful, and they are so mild in nature that you cannot pick it up. Next, please. So these are the various life domains. You take the social domain, the familial domain, the stress coping, the educational domain, the physical domain, the mood and thought, the physical abuse, the personal domain, interpersonal domain, the behavioral domain. 10 domains, all of these life domains, they are infected. So how do we do this? And that is mapping stress. This is a 93-item validated, reliable measure of capturing the troubling life stressors across the multiple domains of a person's life. And it has got the physical domain, the personal domain, the interpersonal, social, behavioral, familial, stress coping, physical and sexual abuse, mood and thought, and educational domains. And more importantly, it takes only 20 minutes. It is self-administered. It takes about 20 minutes. We routinely use it. It's very relevant. Next, please. Next, please. Yes. This is a 3-point Likert scale is used, 0, 1, and 2. And this will comprehensively map. Next, please. So I'm not going into the scoring. Next, please. Now, let me show you the graph. Next, please. Next, please. Yes, let me show you the graph. Now, this is the graph. Now, more than 40%, if the stress is mapped in any domain, more than 40%, we give a red color. And through this red color, you can make out which are the domains which need to be addressed. And through this, you can sort out your non-pharmacotherapy. Next, please. The cumulative stress load, it says that the domain 1 to 10, you add up all the scores from all the domains and you get a cumulative stress load scores. Next, please. Then there is also the concept of qualitative analysis, that is independent and dependent stressors. I don't think I'll go into it. Next, please. The tool is reliable and validity. The Cronbach's is 0.865. Next, please. Next, please. Yes. Now, these are the graphs for the various individuals, and what we are presently trying is we are mapping their stresses, though we have not published till now. The study is still undergoing, and we are mapping the stresses of these people who are coming with either internet disorder or gambling disorder or compulsive buying. And as you can see, the red,
red graph. Sir, you have only 2 to 5, 4 more minutes to complete your topic, sir.
Yes, sir. I will finish in 2 minutes. Next, sir, please. So the interpretation of this graph is that you can add up all the domains and you will get a cumulative stress load. The previous graph that you saw, the cumulative stress load was 490. Next, please. And this is, you can see, this is at week 1 and how you can follow up. Next, please. This is week 2. You can see how the stress is being attended to through the non-pharmacotherapy. Next, please. This is another case in which this, next, please. The cumulative stress load is 380 in this. And you go to next, please. 2, 3 more slides. Yes, you can see this is going down. Next, please. And then you can see that all of the red has been eliminated. And just one word about, last please, next please. Just one word about the pharmacological management. Though the psychological treatments are the major form, the drugs that have been studied are naltrexone, naltrexone, bupropion, topiramate, lithium, valproate, and SSRIs. But they have been found to be more effective than placebo. And naltrexone in high doses is the most promising drug, but the evidence has to be coming in. Next, please. Next, please. Next, please. Next, please. So with these words, I'd like to say that behavioral addiction is exceedingly rampant in our OPDs. It is a demand of the society. The psychiatrists should be geared up, and we say that we should always update and upgrade ourselves. I think most of us have not focused on this, and I'm very thankful to Dr. Ram Ghulam Razdan and to the organizing committee for choosing this beautiful topic, which is very, very relevant. And I would exceedingly urge all the PGs to go in detail into these things. Thank you. Thank you very much.
Yes, sir. आपका तो सर सुना मैंने.
Thank you. Thank you. Thank you very much. Thank you.
Very informative and presentation and very useful for the
Sir, I want to ask one question to Dr. Sanjay Gupta, sir.
I cannot answer a question from the chairperson. The chairperson is the chair.
Okay, sir.
No, please. I'm just kidding. You please come with your question.
Sir, I'm really sorry, sir. Now the problem is that the most of the children after this pandemic, they're spending most of their time on internet and obviously internet gaming, and almost 8-9 hours of screen time they are spending on this thing. So this ICD-11 has come up with new category that intergaming disorder. It has now been an official category of addiction. Now my point is there are many diagnostic issues in this category. First of all, when you talk to these children and the adolescent, they give a logic that they want to pursue this as a career. Like eSport. Even today's news that many of the internationally and in India also, people are pursuing this as a career. So they argue with their parents. They don't want to come to a psychiatrist. They think that they're behavior and this is a very normal thing. So my point is how to assess these kids and how to pursue them to psychiatrist's opinion.
Right.
One more question is that you describe about this Griffith criteria. and now ICD-11 also, the newer criteria, the main criteria, the tolerance, withdrawal, and the craving, they have given the backseat. Now, so with these new diagnostic guidelines and with these children who are not accepting their behavior as an addiction behavior, so how to approach them, and sir, few tips. Although you have mentioned some points regarding treatment of these kids, but sir, my point is that complete abstinence is basically not possible, because the parents are also spending lots of time on internet. So this complete abstinence in home is sometimes not practically possible, because it is not always possible to monitor the kids' behavior 24 hours a day, because nowadays both parents are working. So, sir, few tips from you, sir. Please.
I think, Mr. Chairperson, a very relevant, and that's why I said it is a burning issue of today. And I remember about 4 or 5 months ago, of course, now the press has left me because now they understand my thoughts. But 4 months ago, the press used to say, please tell me about the hazards of this mobile and screen time being used and all that stuff. So what I explained to them, I just like to share. See, we have the concept of the PRC. I call it the PRC. The PRC model says that pre-morbidly, I mean, not morbid, but previously, whatever the person, you said, an individual said, he wants to pursue this career. So you look at maybe before Corona or maybe 1 year, 2 years ago, was this person very interested in the computer, in the online? If the person is yes, then you can go ahead and maybe consider that as a routine thing for a career, because no doubt psychiatrists have to understand that this is a very, very upcoming career opportunity. So one is premorbid. The second that you have to see is the rational use of the time. Though whether the person is doing 8 hours or 9 hours, you have the kids, they are doing 6 hours of school. So if the 6 hours of school are being rationally used, there is no problem. So that is PR. And C is how much constructive activity, how much constructive thinking are you getting out of it? These three questions, along with the stress SSDQ model, will give you an analysis of whether this person needs what type of lifestyle change. Because I told you, pharmacological is not in, and psychiatrists are not equipped with lifestyle changes until you use the SSDQ. Because one of the most important problems, when a person comes to you, you feel that you start telling, this person is in this stress. This is absolutely wrong. Stress is very individualistic, and only the person can tell you what his stress is or her stress is. That is how you have to use a scale. The PSLE used to be there, but that is for things like earthquakes, volcanoes, death, and all of that. This SSDQ is for the daily stressors. So it maps the things wonderfully, and then you can pinpoint, you can make lifestyle adjustments, and we find that the people, once you show them these graphs, you see, people are not ignorant. The only problem is psychiatrists do not have things to show the patient. So once you show the patients these things, the patient will understand.
Okay.
So,
sir.
Of course, it's very important. Yes.
Thank you, sir. Thank you. Got your answer.
Thank you. Thank you.
Thank you. Thank you. So, Dr. Dhiren Mishra, would you like to comment something? Unmute your, please first unmute your this thing.
Hello, Dr. Robert. As like other substance addictions, similarly the behavioral addictions is also the various comorbidities. So when we are dealing with these kind of cases, also the assess for various comorbid personality traits, ROC symptoms, or impulse control, then this will give a more clear picture about how to approach these kind of patients and how to manage the situations. Thank you, sir.
So thank you, sir.
Yes, but only one thing I would like to say in response to Dr. Dhiren. Again, we should not focus on the comorbidity only.
Yes.
Because the behavioral addiction is the primary focus. Though we are not comfortable with it, we have to devise the mechanisms to tackle it. So that should be the primary focus.
Thank you, sir.
Thank you.
Sir, with this, we conclude this topic. Over to the organizer, sir. Thank you very much.
Thank you, Dr. Sanjay Gupta, Dr. Prabodh, Dr. Mishra, for chairing the session. Now, moving to the next session, substance abuse and sex disorder.